So let's start with Introduction to Thorax. Now, the learning objectives are that at the end of the lecture, the student should be able to describe the superior and inferior apertures of the thorax, the boundaries and contents, describe the thoraco-abdominal diaphragm in detail, and describe the respiratory movements. Now, what is thorax? Basically, it is the chest forming the upper part of the trunk of the body, not only permitting the boarding and the lodging of the thoracic viscera, but also providing necessary shelter to some of the abdominal viscera as well. The trunk of the body is divided by the thoraco-abdominal diaphragm into an upper part called the thorax and the lower part called the abdomen. Now, the thorax is furthermore supported by the skeletal framework called the thoracic cage. The thoracic cavity contains the principal organs of respiration, that is, the lung and the heart for circulation. Both of them are vital for life. Coming to the superior aperture or the inlet of the thorax, it is the narrow upper end of the thorax which is continuous with the neck above, and this is called the inlet of the thorax. Roughly kidney shaped over here, the transverse diameter being 10 to 12.5 centimeter and the anterior posterior diameter about 5 centimeter. The boundaries now. Anteriorly, the upper border of the manubrium sterni. Posteriorly, the superior surface of the body of the first thoracic vertebra. And on either side is the first rib with its cartilage. Now, the plane of the inlet is directed downwards, forwards with an obliquity of about 45 degree. This is the manubrium sterni over here, right? And this is the 45-degree angle because it is slanting, it is oblique. The anterior part of the inlet over here is lying about 3.57 centimeter below the posterior part. You can see it is lower down, the anterior part, so that the upper border of the manubrium sterni, which is this part, lies at the level of the third thoracic vertebra. Now, the partition at the inlet of the thorax, it is partitioned in two halves, right and left, with a cleft in between. Each half is covered by a fascia called a Simpson's fascia or the suprapleural membrane. It partly separates the thorax from the neck, and you can see that this membrane is triangular in shape. Now, the apex of this triangle is attached to the tip of the transverse process of the 7 cervical vertebra and the base of the inner border of the first rib, and the cartilage has been removed. Morphologically, the Simpson's fascia is regarded as the flattened tendon of the scalenus minimus muscle, also called pluralis. Thus, it is formed by the scalenus minimus and the endothoracic fascia. Functionally, it provides rigidity to the thoracic inlet so that the root of the neck is not puffed up and down during respiration. The inferior surface of this membrane is fused with the cervical pleura over here. We will discuss the pleura in detail, beneath which lies the apex of the lung. Now, this is the suprapleural membrane over here, superiorly related to the subclavian vessels and other structures at the root of the neck, which we shall discuss further on. Now, very important, the structures passing through the inlet of the thorax. This is the inlet. Amongst the viscera, we have the trachea, the esophagus, the apices of the lungs with the pleura, and remains of the thymus gland, not shown in this picture. Then we have the large vessels. We have the brachiocephalic artery on the right side. On the left side, we have the left common carotid artery and the left subclavian artery on the left side, and the right and the left brachiocephalic veins. These smaller vessels include the right and left musculophrenic, internal thoracic arteries over here, the right and left superior intercostal arteries, the right and left posterior intercostal arteries and veins, and the inferior thyroid veins. We'll discuss about the intercostal arteries and veins in detail in the further lectures. Now, amongst the nerves, we have the right and the left phrenic nerve, right and the left vagus, the right and the left sympathetic trunk, as you can see, and then we have the right and the left first thoracic nerves as they are ascending across the first rib to join the brachial plexus. Amongst the muscles, we have the sternothyroid, the sternohyoid, and longus colli passing through the inlet of the thorax. Now, what is the cervical rib? Basically, C7 does not have a rib, but in case it does, that is called a cervical rib, as you can see over here, occurring in about 0.5% of patients, and such a rib can exert traction on the lower trunk of the brachial plexus, as you can see, which arches over the cervical rib. So now, this person may complain of paresthesia or abnormal sensations along the ulnar border of the forearm, wasting of the small muscles of the hand supplied by segment T1, and vascular changes may also occur. Now, in coarctation or narrowing of the aorta, right, it's a congenital condition, the posterior intercostal arteries, they get enlarged greatly to provide basically a collateral circulation. The pressure of the enlarged arteries are so much so that it characteristically causes notching on the ribs, especially in the posterior parts. Now, what is the thoracic inlet syndrome? Two basic structures are arching over the first rib, that is the subclavian artery and the first thoracic nerve. These structures may be pulled or pressed upon by a cervical rib or by variations in the insertion of the scalenus anterior, and the symptoms may therefore be vascular, neural, or both. Coming now to the inferior aperture or the outlet of the thorax. The inferior aperture is a broad end of the thorax which surrounds the upper part of the abdominal cavity but is separated from it by the diaphragm. The boundaries of the inferior aperture: anteriorly, we have the infrasternal angle between the two costal margins. This is the infrasternal angle. Posteriorly, inferior surface of the body of T12 thoracic vertebra. Over here you can see. And then on each side, we have the costal margins formed by the cartilages of 7th to 12th rib. Okay. So this is 7, 8, 9, 10, 11, 12 are floating ribs. Now, the inferior aperture and the outlet of the thorax, I told you before, we have the diaphragm at the outlet of the thorax. This outlet is closed by a large muscular tendinous partition called the diaphragm, the thoraco-abdominal diaphragm, which is separating the thorax from the abdomen, right? Now, very important are the structures passing through the diaphragm. As you can see, it has three large openings, right? And they are allowing passage of structures from the thorax to the abdomen and vice versa. You can see we have the inferior vena cava, the esophagus, the aorta passing through it. Right. So what are the large openings? We have the vena caval opening in the central tendon. This part of the thoraco-abdominal diaphragm is called the central tendon. The esophageal opening in the right crux of the diaphragm, so the right crux is the left crux, and the aortic opening behind the median arcuate ligament. This is the median arcuate ligament. You can see the caval opening, the esophageal opening, and the aortic opening. Coming to the small openings, we have the superior epigastric artery mentioned in your Chaurasia, whereas the internal thoracic artery is mentioned in grays. Basically, Superior epigastric artery is the terminal branch of the internal thoracic artery only, right? And this space is called space of Larry, present between the slip of the xiphoid process and the seventh costal cartilaginous slip at the diaphragm. When this foramen is enlarged, it is called foramen of Mergagni. The musculophrenic artery, which is the other terminal branch of the internal thoracic artery, perforates the diaphragm at the level of the ninth costal cartilage. Now, the lower five intercostal vessels and nerves pass between the costal origins of the diaphragm, these are the costal origins, and the transversus abdominis. The subcostal vessels and nerves, they are passing behind the lateral arcuate ligament. This is the lateral arcuate ligament. They are passing behind it, not seen in the diagram. We also have the sympathetic trunk passing behind the medial arcuate ligament, mind you. This is the central tendon, right crux, left crux. This is the median arcuate ligament. This is the medial arcuate ligament. This is the lateral arcuate ligament. The sympathetic trunk, as you can see, is passing behind the medial arcuate ligament. The greater and the lesser splanchnic nerves, you can see greater and the lesser splanchnic nerve is piercing each crux, right? It is piercing on either side, the left and the right both. The left phrenic nerve is piercing the left cupula of the central tendon, whereas the right phrenic nerve is piercing the muscular part. Now, coming to the respiratory movements. As you can see, the lungs are expanding during inspiration and retracting during expiration. Now, these movements are governed by the following factors. Firstly, alteration in the capacity of the thorax are brought about by the movement of the thoracic wall. Increase in volume of the thoracic cavity, basically it is causing a negative pressure, intrathoracic negative pressure, which is sucking in the air into the lungs. Also, movement of the thoracic wall occurring chiefly at the costovertebral and the manubriosternal joints. Elastic recoil of the pulmonary alveoli and that of thoracic wall also is helpful in expelling air from the lungs during expiration. Now, principles of movement. Each rib can be regarded as a lever, and the fulcrum of which lies just lateral to the tubercle. Okay, this is the tubercle lies just lateral to it, the fulcrum. And because of the disproportionate length of the two arms of the lever, okay, one, this is small and this is huge. You can see how disproportionate they are. Even the slight movements at the vertebral end of the rib are greatly magnified at the anterior end, as seen in this video. You can see, right, there's a small movement occurring behind, followed by a greater movement occurring at the anterior end. You can see over here, here, small movements here but huge movements here, greatly magnified movements are over here. Also, the anterior end is lower than the posterior end, as you can see. Therefore, with the elevation of the rib, when the rib elevates, it is also moving forward. And basically, this movement is occurring in the vertebrosternal ribs, these ones. Okay, 2, 3, 4, 5. Along with the up and down movements of the second to the sixth rib, the body of the sternum is also moving up and down, and this is called the pump handle movement. And in this way, the anterior posterior diameter of the thorax is increasing, right? You can see it is moving up and down from second to sixth rib, and the body of the sternum is also moving up and down like a pump handle. Okay. So how is it moving? Let's just quickly have a look at this. Right. So this is the thorax. We have the ribs. We have the upper ribs, okay, not the lower ones. They're not contributing so much right now. And then they're attached to the manubrium and the sternum. This is the costocartilage over here. Now, they are moving anteriorly, okay? The sternum is moving anteriorly and superiorly. Just have a look, okay? Right. So, sternum is pushed anteriorly and superiorly. Okay? Anteriorly and superiorly at the manubriosternal joint. Okay. So you can see the sternum moving anteriorly and superiorly, increasing the anterior posterior diameter. The anterior posterior diameters, okay? Anteriorly, superiorly, like a pump handle. This is the sternum, okay? Anteriorly and superiorly, causing the increase in anterior posterior diameter. Also, you can see that the middle of the shaft of the rib lies at the lower level than the plane passing through the ends. Therefore, during elevation of the rib, the shaft also moves outward. You can see the shaft, it is also moving outwards, right? So this outward movement is increasing the transverse diameter of the thorax, and this basically is occurring at the vertebrochondral ribs, also called the bucket handle movement. How? Here, have a look at this. So can you see the lower ribs are moving outwards? There's a lateral movement. These ribs over here, lateral movement. Okay, they are more angulated and have an indirect attachment at the sternum, resembling a bucket handle. Okay, these are the factors contributing to it, and there is more motion in the lateral aspect. Yeah, you can see they're moving laterally. So lower ribs make an upward rotation and elevation like this, and in doing so they are increasing the transverse diameter, and this is your bucket handle movement. Okay, increasing the transverse diameter. Now, the thorax basically, as you can see, it is resembling a cone, okay, tapering upwards. As a result, the each rib is longer than the next higher rib. Okay, this is longer than this is longer than this. So, on elevation, the lower larger rib comes to occupy the position of the smaller upper rib, which is pushing the sternum forward. Okay, you can see the lower rib comes up and is also pushing the sternum forward. Okay, this also increases the transverse diameter of the thorax. The vertical diameter is increased by piston movement of the thoraco-abdominal diaphragm, as you have seen previously.